Hello, I'm Emily. I'm one of the haematology regis, and my QI project was about nurse authorisation of blood. So just a little bit of background. Can't be a haematologist without a nerdy slide blood film, I'm afraid. But we have a number of patients within the haematology department who are transfusion dependent, ranging from different diagnoses such as myelodysplasia. Some of our myeloma patients who've had multiple rounds of treatment, rendering them transfusion dependent, which is what this blood film is meant to represent for you, and a few spatterings of other haematological diagnoses that require regular transfusions. What currently happens for these patients is they come to clinic, they have their full blood count done, the consultant or the registrar in clinic will decide how much blood they will need, prescribe it in clinic, and then they come to our day ward subsequently to have their transfusion. There are some patients that find this process quite a long wait, and it sometimes means that they can't get all of their blood transfusion in one day because of the time pressures. So some consultants on an ad hoc basis are letting the nursing staff on the day will perform the bloods and then come to them with a result and prescribe the blood without actually seeing the patient. So it's not an ideal situation and is based on the doctor's prior knowledge of the patient. But also involves the nurses chasing around after us, trying to find one of us to prescribe the blood. So as you can imagine, this isn't ideal, and therefore I thought if we could get this QI project up and running, hopefully we would save time for the patients. So since 2009, NHS Blood and Transplant and the British Committee on Standards in Haematology have both allowed non-medical prescribers to authorise blood. Now, I'm using prescribing incorrectly really because technically we're not prescribing blood, we're authorising it. That means that the nursing staff don't need to do the prescribing course, they just need to do a special blood authorisation course, which senior midwives and nursing staff are allowed to do. The idea is to enhance the patient care, allow the nurses to have more autonomy in their decision making and thus improve the service to our patients. So this is, I know you won't be able to read all of it, but it's the basic summary of what the nurses undertake in their non-medical authorisation of blood component course. It's a 3-day course. To be honest, it's probably a lot more detailed than our junior doctors are receiving on the wards, and they will actually be better placed to understand the whole process from donation, how the blood is processed in NHSBT when it arrives as whole blood and is then separated, the whole cross-matching procedure in much more detail than I certainly was taught at medical school, and how to decide when to prescribe, how much to prescribe, as well as the risk factors, particularly transfusion-associated circulatory overload, which is the big one that we should all be worried about. So my smart aim is that 50% of our transfusion-dependent haematology patients will have nurse-led authorisation of their red cell blood products within our day ward by the end of July. My main outcome measure will be the number of red cells that are authorised by the nurses per month, and then my other measures, my process measures, etc., are the number of patients enrolled, the time taken for their transfusion, will this go down, hopefully, will we be able to save clinic visits, are the staff, both medical and nursing, as well as the patients, happy with this process? Does it help the autonomy of the nursing staff in particular? And kind of as a balancing safety measure, are there any more transfusion reactions? I'm not anticipating this, but obviously I thought it was an important thing to balance out. So, what have I done? I think, as we've all said, not as much as I had hoped I would get done by this time, but nevertheless. We have a patient information leaflet now for the patients who are going to go onto this scheme, explaining what it involves, so that they know that the nurses are trained to do this in addition, and therefore they feel confident in going onto the programme and know that they will still see their consultants appropriately. We have a pro forma which has undergone many rejigs, but this is the final one, hopefully. So on one side of the pro forma, this side you can see here is for the medics to fill in clinic for the patient to go onto the system. So we're asking that their special requirements are completed so that we know that that's done. because they're having regular blood transfusion and transfusion dependent, we're doing extended red cell phenotyping so that we can accurately cross-match them. The consent for the transfusion should be done by the doctor who's initiating it. Any prescriptions, PRN that they need, like frusemide, and then a trigger and how often we want the full blood count monitored by the nurses. So the big bold boxes are the two important ones for the nurses to have the information that they need. Then on the reverse, in order to help us, the nurses will record how many units they've given on each occasion so that we can assess whether transfusion requirements of the patient are increasing and therefore whether we need to change our management plan. There's also a box for the nurses to raise any concerns, and then an aid memoir for the nurses at the bottom about TACO. So this will all come in a nice pack with this proforma, the patient information leaflet, the special requirements form, a transfusion chart and a drug chart, so that everything will be in one folder, hopefully making it as easy as possible. So obviously there's been lots of barriers along the way, otherwise I'd have more results to show you. So initially it started off as just focusing on MDS patients. Only a fortnight ago we totally changed our smart aim and spread it wider because we were realising there were too few patients to really put this much work into it and get it off the ground. So the whole proforma was radically redesigned just 2 weeks ago, which felt a little bit demoralising, but nevertheless we're happy with it now. Because this is a big step for the nursing staff and they're taking on a lot more responsibility, I wanted to make sure that they were really happy with the proforma and the support that they were getting from the medical team before that we actually got going. I didn't want them to feel that we were putting them in a risky situation. I wanted them to feel happy with the paperwork they had and confident to implement it. So we are starting on the 5th of March. We're going to pilot it for 3 months and reassess the data as a full cycle. Obviously, during that 3 months, we'll be talking to them as well to make sure there's no teething problems that we can iron out on the way. But I thought if we give it a couple of months, we can get some good data and understand whether it is actually helping rather than just doing it too short when there's too few patients. So, on the horizon, if the pilot goes well, is the option to extend the training so that more of our nurses are able to do this. At the moment, we just have 2 nurses on the day ward who have undergone the additional training I spoke about. So if the pilot goes well, then we're hoping we'll be able to encourage some further the senior nurses to undergo this training and extend it out further.